This month, later in this month, we have World Heart Day. So every September is World Heart Day, and so we thought, in line with that, we'd give a talk really about the prevention of cardiovascular disease. So when people talk about cardiovascular disease, they tend to be talking about cholesterol buildup in the arteries, building up to chest pain, which is angina, and then the possibility of heart attacks. And as we'll see in some of the slides coming up, heart attacks remain the leading cause of death worldwide. So cardiovascular disease, which includes heart attacks and strokes, to be fair, is still the leading cause of death and a major healthcare problem. And so we're going to talk about some of the risk factors in developing cardiovascular disease, which is going to hopefully help us to prevent this disease entity. So my slides are not moving. Have you given me control about slides? Here we go. All right, so the learning objectives for today's talk is to understand what coronary heart disease is and the extent of the problem, to understand the major risk factors for coronary artery disease and therefore to discover means of reducing one's risk, and to gain a broad overview of the symptoms, investigations and treatments for coronary artery disease. So just a bit of background. Cardiovascular disease, as I mentioned before, is the leading cause of death worldwide. And if we look at figures from about a decade ago now from the Global Burden of Disease study in 2013, cardiovascular disease accounted for approximately 30% of all deaths globally. If we look at the UAE in particular, then it's even greater proportion, with 37% of all deaths in 2013 due to cardiovascular disease. And the average age of a patient presenting with a heart attack in UAE is approximately 45 years, which is about 15 years younger than a patient presenting with their first heart attack in Europe. And so clearly in this geography, we have a high prevalence of cardiovascular disease, principally due to very high prevalence of the risk factors causing cardiovascular disease. And we'll talk about that in a second. And when we talk about cardiovascular disease, it is a combination of heart attacks and strokes. So strokes affecting the brain and coronary heart disease causing heart attacks.
Doc, I think the session froze.
Sorry? Can you hear me?
Hello, Doc.
Yep. Can you hear me? Can you hear me?
Doc, I think the session froze.
Oh. Can you hear me now?
Yeah, we can hear you now, Doc. So we may have missed few part of it.
All right. Did you? Okay. I mean, but you can hear me now clearly?
Yeah, we can.
All right, great. So I think the session froze a little bit, so I don't know where we got to, but you can hopefully see the slide. Have you been able to see the slide the whole time?
Yes, we can see the slide.
All right, so basically, without kind of going over from the beginning, it's really just recapping that cardiovascular disease is the leading cause of death worldwide. It includes heart attacks and strokes. And that locally in the UAE, we have a high prevalence of disease, and that's principally due to the high burden of risk factors that we see locally here. We're going to talk about those shortly, but principally it involves high rates of diabetes, hypertension, obesity and smoking. But what we know on a positive note from cardiovascular disease is that we have very good treatments. We have very good means of prevention, and that is something that we need to explore more aggressively, because 70% of all cardiovascular disease is preventable. And that, for me, is the most alarming statistic of all, because when you're talking about the leading cause of death, if 70% of those deaths are preventable, then we really need to be doing our utmost to do so. And that is a responsibility upon us as healthcare professionals to be treating risk factors like blood pressure and cholesterol and diabetes more aggressively. But it's also incumbent on everybody in the population to do what they can to prevent ever becoming a patient. And that involves basically leading a healthier lifestyle. But there are other treatments of heart attacks, for example, that have improved enormously over the past decade or so, and that in part has improved the survival from heart attacks, also called myocardial infarction, over the past decade. So the heart's a very simple organ. There's only 4 things that can go wrong with the heart. And that is the plumbing, and that pertains to the blood supply of the heart. So this is coronary heart disease, and the principal symptom of that would be chest pain. So a patient might present with a central pressure on their chest, sometimes going down the left arm, usually brought upon by exertion and eased by rest. And that's what we're going to be focusing on later, and that's indeed my area of interest. Oops, sorry. So that's not, sorry, let me just go back. The other things that can go wrong are the electrics of the heart, so that's heart rhythm problems causing symptoms such as palpitations, dizziness or blackouts, and the subspecialty interest of that is electrophysiology, where we have cardiologists who explore principally just the electric circuits of the heart. Then there's pump failure, so the heart is just a muscle pump, pumping blood around the body all day long for your entire life, so 60 beats per minute, 80 beats per minute, whatever it may be. And the pump can fail principally due to a heart attack or possibly due to other diseases of the heart muscle itself. And the main symptom of pump failure is breathlessness. And then the final thing that can go wrong with the heart are the valves. So within the heart, we have heart valves that separate the heart chambers, and the valves can become either narrowed or leaky during the course of our lifetimes. And this can cause symptoms such as chest pain, breathlessness, or blackouts. But as I said at the beginning, we're going to focus on the plumbing, which is coronary artery disease. So what is coronary artery disease? Well, it refers to the development over time of fatty deposits building up within the heart arteries, and these are called plaques or atherosclerotic plaques. And the process of buildup of cholesterol in the arteries is called atherosclerosis. And indeed, this is part of aging, so we can't deny this process. It's happening in us all of the time, but it can be accelerated for different reasons, such as various risk factors, such as smoking. And when we develop buildup of cholesterol in our arteries, this is coronary artery disease. So as I said, it's happening from the first decade of life with depositions of different cells, foam cells, then fatty streaks, and over time we develop what's called an atherosclerotic plaque, so a buildup of cholesterol that basically blocks the hole through which blood is flowing. And if that buildup gets to a certain level, then you can get a critical limitation of blood flow down a coronary artery that can lead to the development of chest pain or angina. And this is pain coming from the heart muscle because the heart muscle is being starved of oxygen, and oxygen is carried in the blood. And so if you don't get enough blood to the heart muscle, the muscle starts to ache and you get chest pain. Heart attacks happen because actually the cap of this cholesterol buildup breaks, and I don't know if you can see the cursor there, but when that plaque breaks, then the blood that's flowing through the artery wants to form a clot at the site of that fracture, and it's a buildup, an acute buildup of blood cells that acutely block an artery, and that's what causes a heart attack. So although the processes are linked, having a blockage doesn't necessarily mean you're going to have a heart attack, but it does increase your risk of one. So this is again just another cartoon to depict what happens within the coronary artery. So a normal coronary artery would be nice and smooth and a smooth tube. As you develop cholesterol buildup within the artery, then you get a blockage such as there is a narrowing within the artery, which restricts the amount of blood that can get to the heart muscle. If a blood clot develops in that narrowing, then it can completely block the artery, and that's what leads to a heart attack. So what are the risk factors for developing coronary artery disease? Well, broadly speaking, you have two sets of risk factors: the non-modifiable risk factors, so things that you can't change, and then the modifiable risk factors, things that you definitely can change. So the non-modifiable risk factors would be age, sex, although I guess in current times even that's questionable, but we won't go into that, your family history and race. And then the things that you can change, so the things that we're going to focus on in this talk are going to be smoking, your cholesterol buildup, blood pressure, diabetes, obesity, alcohol consumption, and physical inactivity. So how does smoking cause harm? So without doubt, the most potent risk factor for developing heart disease is smoking. And smoking damages the lining of your arteries, leading to the buildup of fatty deposits. So it makes it more likely for cholesterol to attach to the walls of the artery and cause cholesterol buildup within your arteries. On top of that, smoking leads to a buildup of carbon monoxide, and that competes with oxygen for your red blood cells. So the end result is that you have less oxygen being carried by your blood, and therefore the heart has to pump harder to supply your body with oxygen. Then you have nicotine, and nicotine itself is a harmful agent. So people who think that vaping is perhaps harmless would be wrong, because anything that contains nicotine stimulates the body to produce adrenaline. Adrenaline is one of your stress hormones, and it's fine in the sort of fight or flight kind of survival mechanism where we need adrenaline for physical activity, for example. But too much adrenaline constantly is a very harmful agent, because it increases your heart rate, increases your blood pressure, and causes it more likely for you to have cholesterol buildup in your arteries. And then finally, smoking itself also makes your blood more likely to clot, which therefore also increases your risk of a heart attack or stroke. So although we said that atherosclerosis is part of the aging process, certain things accelerate that process, and smoking being the fundamental one. And so it's imperative that we, if you are a smoker, that you stop smoking, and that we encourage anybody who is a smoker to stop smoking, and do anything that you can to stop smoking. So there we go, that's the final message. I won't harp on about smoking cessation anymore. Next one would be cholesterol. So people are familiar with having, or the concept of high cholesterol being bad for the heart, but it's not just so simple as saying somebody has high cholesterol. There are different types of cholesterol. Some are good, some are bad. And it's important to understand the difference between the two, and to get that full amount of information when you do a blood test to check your cholesterol levels. So your good cholesterol is your HDL cholesterol, your high density lipoprotein, and this cholesterol molecule brings cholesterol back to your liver for it to be metabolized. Whereas your LDL cholesterol, your bad cholesterol, deposits into the linings of your arteries, causing blockages in your arteries. And so there is a distinction. Having high HDL is protective, whereas having high LDL is a negative effect and a major risk factor for developing heart disease. The other important thing to recognize about cholesterol, and this is something that I see in the clinic a lot, where patients will tell me, oh look, I'd rather wait to take a tablet and just try diet alone. And that's fine if you have borderline cholesterol, whereby you just need to reduce your levels by 10, 20%, something like that. Because actually only about 25% of your cholesterol value that you see on your blood report is derived from your diet. The remaining cholesterol, about 75%, is metabolized in your liver. So you can't change that. That's just the genetics of how you're put together. So basically everybody's high cholesterol is a genetic thing. Sometimes it's a genetic mutation that is inherited in families, whereby there is a genetic mutation on one of the molecules responsible for your cholesterol metabolism, which means that patients will have a very, very high level of cholesterol. But for the masses, for everybody who has slightly high cholesterol, let's say, it's really just a function of how your liver is overproducing cholesterol, and that's just the genetics of your own biochemistry. So that's not to say you shouldn't try hard to lower your cholesterol with your diet, but it is saying that there is a limit to how low you can lower your cholesterol with just diet alone. But it's important to know your numbers, and so this is just broadly speaking a cholesterol profile. So it's not good enough to just know your total cholesterol. In fact, in many respects, it's pretty irrelevant to know what your total cholesterol is, because it doesn't determine whether you need treatment or not. What is more important is to know your LDL cholesterol and your HDL cholesterol in particular. And you can go into even more detail with VLDL cholesterol, which is very low density lipoproteins, which is even more specific a risk factor for developing heart disease. But broadly speaking, a fasting lipid profile, which is what you should have done, will give you these measures that you see on the screen: your total cholesterol, LDL, HDL, and your triglyceride levels. And those are the values, broadly speaking, that you need to kind of have a handle on to ascertain whether your cholesterol value is normal or not. Now, what I would add is that there's no such thing as a normal cholesterol, only a cholesterol value that is appropriate for you as an individual, because we're all different and we all have other different risk factors. So, for example, if one is a smoker, then the expected cholesterol value might be much lower than a non-smoker, because your cardiovascular risk is much higher as a smoker than if you're a non-smoker. And so whether your cholesterol level needs to be treated or not is not just determined by the actual blood value of cholesterol, but more by your own individual cardiovascular risk. And therefore, it's very important that whoever is interpreting your cholesterol blood profile actually calculates your 10-year cardiovascular risk. And those algorithms are available online. I personally use the American College of Cardiology one, which requires your age, sex, cholesterol values, blood pressure, whether you're diabetic or not, whether you smoke or not. And just those simple demographics and certain biochemical details are enough to be able to broadly calculate your 10-year risk of having a heart attack or a stroke. And that then risk stratifies you to determine whether you might need a cholesterol lowering tablet or not. And the only thing I would say on this is that the only thing worse than knowing you have one of these conditions is not knowing that you have it. So living in ignorance is not bliss. It's much better to understand, what your sugar level is, what your blood pressure is, what your cholesterol level is, so that we can do something about it. So in terms of diet, I mean, I'm not trying to downplay diet as much to say that there is a limit to how much it can lower your cholesterol, but we should all be doing as much as we can in our lifestyles to ensure that we are living as healthily as possible. So when it comes to cholesterol, the things that are good for you would be fruits and vegetables, particularly things like avocado is a good source of good fats. Oily fish like salmon, trout, mackerel are a natural source of omega-3 oils that help to lower your bad cholesterol, but also increase your good cholesterol. Whole grains, nuts such as almonds and walnuts, so unsalted, so they're not putting up your blood pressure, and small quantities, so only about 30 grams of nuts per day, which when you're talking about almonds is only about 10 to 15 almonds a day. If you're talking about walnuts, maybe about 8 to 10. And then when you're using oils, try to use olive oil as much as possible as your preferred choice of oil. And if you don't like to cook with olive oil, then canola oil is probably a good alternative. And when you kind of marry all those things together, then the best kind of overall diet to follow, in my opinion, but it's only an opinion, is a Mediterranean diet, because you don't miss out on anything. It's not, being as strict as, say, veganism, for example, which, as an aside, is probably the best heart-healthy diet. So it's not that extreme, but it's also, you don't need to be as extreme as like a keto diet or something like that. So a Mediterranean diet in composition of your macronutrients has about 40% carbohydrate, 40% fats, and 20% protein. But the increased level of fats comes from good fats, like the oily fish, the vegetables and the nuts, and the use of olive oil. So in my opinion, a Mediterranean diet is the thing that I advocate more than any other. But of course, we are constantly bombarded by temptations from fast food companies and restaurants, etc., to encourage us to eat bad foods. And if you have ever been to Las Vegas, you might have even seen the heart attack grill, which genuinely exists, where you can have a nurse or a waitress dressed in the nurse's outfit serving you your triple bypass burger. And as sexy as they try to make these kind of foods, really try to avoid it as much as possible, because these kind of processed meats are high in trans fats and saturated fats, and these are the precise things that we need to be trying to avoid in our diets to help keep our lipid profiles in an acceptable range. So when it comes to red meat, certainly if your cholesterol level is high, you want to be minimizing red meat consumption to maybe once per week maximum. People always ask me about eggs, and I would say maybe 6 to 8 egg yolks per week is fine. So the cholesterol aspect of eggs comes from the yolk. The egg white is just albumin, which is pure protein, so that's actually healthy. But the yolks you want to minimize to about 6 to 8 yolks per week, which means if you really do like eggs and you're having 2 eggs a day or something, then just take the yolk out of one of the eggs, and then you can still have your 2 eggs per day. Try to avoid kind of too much dairy, so cheese in particular, full fat milks, full fat yogurts, processed meats for sure, high in saturated fat and trans fat. And lowering these kind of things in your diet will help to lower your LDL cholesterol. So the next major risk factor is blood pressure. So what is blood pressure? Well, blood pressure is a measure of how easy or difficult it is for blood to exit the heart, so to be pumped from the heart into your bloodstream, into the aorta, the main blood vessel leaving the heart, which provides oxygenated blood to your entire body. So when the heart and blood vessels are healthy, your blood vessels are flexible. So they're tubes, muscular tubes that are flexible. They can expand and contract. But if the expansion and contraction is restricted, so the aorta is a bit stiff, then the blood pressure increases, and this leads to hypertension or high blood pressure. So this is an important risk factor for heart disease, and what we're trying to aim for is a blood pressure that is less than 130/80. It used to be that the cutoff was 140/90, but the guidelines changed about 5 years ago, and we're getting more and more aggressive about how we treat blood pressure, because we know that it's a major risk factor for heart attacks and in particular strokes. And the key thing about cholesterol, blood pressure and even diabetes, as we'll talk about later, is that patients tend to have no symptoms. So nobody really has any symptom of high blood pressure. Now, if your blood pressure is screamingly high, you might get things like headaches or some visual disturbance sometimes. But otherwise, you tend not to know what your blood pressure is. So the only way you're going to know is if you get it checked. So it's really important that at least once a year, certainly if you're over the age of 40, that you know what your blood pressure is. So you get it checked and you know what your blood pressure is. And there are certain lifestyle choices that can help you control your blood pressure. So keeping a healthy weight. So your body mass index is a good measure of an acceptable weight as reference to your height. So the body mass index is your weight in kilograms divided by your height in meters squared. And normal would be 20 to 25 for the Caucasian population. Overweight is 25 to 30. Obesity is 30 to 35. Severe obesity is a BMI of 35 to 40. And morbid obesity is a BMI of greater than 40. And morbid obesity means that your weight is likely to cause you health problems. Now, like I said, so normal would be 20 to 25. If you're from the Indian subcontinent, then actually the expectation is your BMI is about 2 points lower. So 18 to 23 would be normal, 23 to 28 is overweight, 28 to 33 is obesity. And the reason is that people from the Indian subcontinent, we unfortunately have a higher rate of metabolic diseases such as diabetes, so we're at increased risk of that, and therefore we need to have a lower body mass index. So what can help you with keeping your weight normal? Well, we've talked a little bit about diet already with respect to cholesterol, and we'll talk about diet with respect to sugars later, but eating a healthy diet helps to also lower your levels of sodium. So you want to be, particularly when it comes to blood pressure, monitoring your salt intake. And one of the things I say to patients who have high blood pressure is never add salt at the table. So you don't really need it as a condiment on the table. Whatever salt the food has to be prepared with, and of course we all accept it has to be prepared with some salt because it gives taste, but minimize the amount of salt that you prepare your food with, and certainly get out of the habit of ever adding salt at the table. Similarly, understand that restaurant food, takeaway food, is almost always high in salt because it gives it more taste, and you know, these companies want you to be coming back for more. So be vigilant about that. And then regular physical activity will also help to lower your blood pressure, and so that's important to get some regular exercise. And how much physical activity should you do? Well, when we look at the recommendations from the American Heart Association and the European Society of Cardiology, both societies are kind of aligned in their recommendations, and that is that the minimum expected level of exercise for an adult is between 30 to 60 minutes of moderate to vigorous physical activity 5 days per week. So that's about 150 minutes to 300 minutes of exercise every week. And physical activity helps to lower your heart rate and also lower your blood pressure, which therefore both protect you against heart disease and stroke disease. And there are other benefits, of course, of physical activity, so raising self-esteem, improving your mood, helping you sleep better, just generally giving you more energy, and lots of these things will just improve your quality of life. So physical activity is very, very important. And we all kind of give excuses, I guess, as to why we haven't joined the gym or why we haven't done any exercise, and that we make time the issue. And I guess, you know, we've got to ask yourself these kind of questions. You know, what fits your schedule better, exercising for 1 hour a day or being dead 24 hours a day? So a little bit harsh maybe, but try to get out of the excuses that we make for ourselves. And what as I say to my patients is, you know, dedicate 30 minutes per day to some exercise and keep it simple. So people will often tell me, yeah, I'm going to join a gym later, I'm going to start taking tennis lessons or whatever it may be. But, you know, we can all walk, I hope, and that's all you need to do. You know, moderate intensity exercise can be as simple as brisk walking. A lot of people have these step counters, Fitbits, Apple Watches that will calculate the number of steps that you've taken in a day. And that's good, don't get me wrong, it certainly ensures that you're not going to be a couch potato. And if you set yourself sort of 5,000, 10,000 steps per day, at least you know you're getting in some physical activity. But just walking at a leisurely pace or in intervals, 1,000 steps in the morning and another 2,000 in the afternoon, that's not going to be enough to raise your heart rate and actually get you fitter. So what you really need to do is dedicate maybe 30 minutes of continuous exercise. So that can be just a brisk walk. And if you're going to do that, if you're outside, have some idea of distance perhaps, such that you're walking about 3 kilometers in 30 minutes. If you're on a treadmill, that's basically setting the treadmill at 6 kilometers an hour and walking for 30 minutes. And start kind of simple. You know, if you're somebody who doesn't do any exercise at all or very little exercise, then just start simply, whether it's 15 minutes, 20 minutes, you know, and then build up to 30 and then maybe, you know, to 60 minutes a day. But start simple, keep it time limited, but set yourself some parameters. And as I said, you know, if 6 kilometers an hour is too quick for you, then set it at 4 kilometers an hour. Walk for 30 minutes. At least you've walked 2 kilometers, but continuously with no breaks. Because what you're trying to do is get your heart rate up to a certain level. And we talk about getting your heart rate to about 80% of your predicted maximum. And your maximum age predicted heart rate, as a rule of thumb, is 220 minus your age. So if you're 40 years of age, let's say, it's 220 minus 40, so your maximum predicted heart rate is 180 beats per minute. And what you want to try to do is get your heart rate up to at least 80% of maximum. So again, if you're the 40-year-old, 80% of 180 is roughly about what, 150, 145. Get your heart rate up to about 145 beats per minute and keep it there for 20, 25 minutes, you know, 4 or 5 times per week. And if you can do that, you will see progress. You will see improvements in your fitness, in your stamina. Your blood pressure may well start to come down, and your resting heart rate will start to come down. And when you see those signs, you know that your exercise is working and improving your fitness. Okay, next major risk factor is high blood sugar or diabetes. So our digestive system breaks down carbohydrates into sugars for energy. So we need glucose for energy. It's our major source of energy. But we find glucose in different types of foods. So refined grains and foods that are high in added sugar are the ones that are digested very quickly and therefore quickly deliver sugar into the bloodstream. And that's what we want to try to avoid. We want to try to avoid high spikes in blood sugar, because what that leads to is high spikes in insulin, which is our hormone that's produced from the pancreas that helps to digest the sugar. Because if we have very high levels of sugar, we get spikes of insulin, and if the sugar levels are too high that the insulin can't cope, then the excess sugar gets stored as fat, and then we gain weight. And then as we gain weight and body fat, our insulin becomes less sensitive. So we develop a situation known as insulin resistance, and insulin resistance is the slippery slope to diabetes. So we want to be trying to avoid high spikes in sugar, which means trying to avoid these refined grains or sugary foods, let's say sweet foods, the cakes, biscuits, sweets, these kind of things that lead to high spikes in glucose. The good foods to have would be whole grains, fruits and vegetables, and other high fiber foods that take longer to digest. And so fiber holds on to the sugar in your gut for longer and releases it more slowly into the bloodstream. So you never get high spikes of glucose. You just get a steady rise in the sugar, which your insulin can cope with, and then basically digest your sugar better or metabolize your sugar better. And like I say, if you get too high levels of blood sugar, eventually this can lead to diabetes. And diabetes can cause major healthcare problems, and it's a major risk factor for heart attacks and strokes, but it's also a major risk factor for small vessel disease, where it can cause problems in the eyes and is the leading cause of blindness, unfortunately. It can cause problems to your kidneys and is the leading cause of end-stage kidney disease and the requirement for dialysis. So diabetes itself can cause multiple systemic problems throughout the body. Yes, it's a major risk factor for heart attacks and strokes, but there are other very significant complications of diabetes. I mean, this isn't going to be a diabetes talk, but just broadly speaking, there are 2 types of diabetes. Type 1, which means your body doesn't make enough insulin to allow you to cope with the sugar levels. And this usually occurs in young people and requires patients to take additional insulin as injections or through a pump. And type 2 diabetes is the one that usually happens in adult life and is more connected and associated with being overweight and obesity, not getting enough physical activity, and this can lead to increasing sugar levels and diabetes, type 2 diabetes. And we've talked about this already. I just mentioned that some of the other problems that can develop, can be related to the eyes, kidneys, foot damage, where you have impairment of the sensation of the feet or impairment of the blood flow to the feet. And again, diabetes is one of the leading causes for amputation of the legs. What are the warning signs? Well, many people who have late onset diabetes won't get any symptoms. And therefore, again, as I mentioned, with blood pressure and cholesterol, it's very important to check your sugar levels on an annual basis, just to make sure that your sugar levels are okay. But at an earlier stage, some of the warning signs would be increased thirst, being frequently tired or hungry, blurring of the vision, passing urine more frequently, so going to the bathroom, particularly at night perhaps, and then maybe any unexpected weight loss. So we're going to summarize all of these things with a helpful message, if you like, from the American Heart Association, which provides 7 simple ways to live better, and this is for a healthier heart. And it basically is saying, make one change today and then you're ready to make another. So you've got to start somewhere. And procrastination is the thief of time, so try to not make any excuses. Look at this talk. If any of these things are sort of resonate with you, is it smoking? Is it physical inactivity? Are you perhaps overweight? Do you know that your cholesterol is a bit high? Whatever it is, focus on one, start and address one, and then we can work on the others gradually. But in life's simple 7, number 1 is avoid smoking and using tobacco products. 2, be physically active every day. 3, eat a heart-healthy diet. So that's one that's low in salt, low in sugar, and low in cholesterol. 4, keep a healthy weight. So that's referring to your body mass index. So your weight is referenced to your height, and keeping a normal body weight is a very, very protective thing against heart disease. Regulate your blood pressure, keep your cholesterol in the normal range, and keep your blood sugar healthy. And remember, you're only ever going to know what your blood pressure is, your cholesterol, or your blood sugar level is if you get it checked. So these are the things that we advocate to check on an annual basis from the age of 40 to make sure that you know what your blood pressure, sugar, and cholesterol are, so that at the very least you can try to do something about it yourselves in terms of leading a healthier lifestyle before perhaps it may be needing medical therapy to help you. Now, finally, I'm just going to end with just a few slides on what happens if you develop chest pain. So all of those cardiovascular risk factors are about preventing the buildup of cholesterol in your arteries and trying to prevent you ever having chest pain, or angina as it's called, and certainly, hopefully, preventing you ever having a heart attack. So how does angina typically present? Well, it's a retrosternal discomfort in the chest. It's usually brought on by stress or exercise, and it's promptly relieved by rest or the use of a nitrolingual spray. If you have all 3 of those kind of components of the symptom, then that's typical angina. Any 2 of those 3 would be atypical angina, and if you only have 1 of those 3, then it's probably non-anginal chest pain. So these are kind of ways that we as healthcare professionals will try and take a history and decide just from the history alone whether a patient may or may not have heart disease. If you do have something that sounds like angina, then these are the usual investigations that we will perform in the outpatient clinic. So we'll do a blood test and we'll check that you're not anemic on the blood count. We'll check routinely your glucose level and your lipid profile. Of course, every patient needs an ECG, an electrocardiogram, to see, are they actively having any signs of what's called ischemia, where the heart muscle is struggling for a blood supply. Are there any signs of a heart attack, etc., on the electrocardiogram? And then more often than not, a patient will have some form of functional stress testing. Now, commonly in the outpatient clinic, we would put patients on the exercise treadmill and exercise them according to a fixed protocol by which we've tested millions of people across the globe, so we can make comparisons. We know what it means if a patient can only perform 3 minutes, 5 minutes, 8 minutes on the treadmill, and we can look at the ECG, sometimes combine it with an ultrasound scan of the heart as well to see what happens to the heart at rest and then during exercise. And that gives us a clue, a level of probability, whether it's low, intermediate or high probability that the patient may have blockages in their arteries, accounting for their symptom of chest pain. We might, in the outpatient clinic or outpatient setting, also perform a CT coronary angiogram. So an angiogram just means taking pictures of the blood vessels, and in this regard, we're taking pictures of the coronary arteries, the heart arteries, which sit on the outside of the heart. And you can do that either non-invasively with a CT scan. So a CT scanner is the giant circular X-ray machine. So you lie on a bed, we would inject some contrast agent through a vein in your arm. As the contrast passes through your body and gets to your heart, you go into the CT scanner, and we can obtain pictures of your heart arteries to ascertain whether there are any blockages or not. Now, the picture quality from a CT coronary angiogram is not the best picture quality that we can get. The optimal imaging test for your coronary arteries comes from performing an invasive coronary angiogram. And this is where we pass a catheter, a long tube, either from the pulse in the wrist or the pulse in the groin, under local anaesthetic, often with sedation. We pass the tube to the heart and we inject contrast agent directly into your heart arteries while taking some X-ray pictures to determine, whether you do have blockages in your arteries, to what extent you have any blockages. And also through the same tubes that are there, we can often fix a blockage by performing a procedure called an angioplasty, where we can balloon open an artery and then implant a stent, which is a metal scaffolding to keep an artery open. Now that, of course, would be a day case procedure and not something we do straight from the clinic setting. But all of the other investigations may well be done in the outpatient clinic should a patient present with chest pain. So this is just a brief outline of a patient who presented with a heart attack as it happened. So contacted the emergency services because of having 2 hours of central chest pain. And when the paramedics got to the patient, they performed an ECG on site, and that showed what's called ST segment elevation, which is a sinister sign that a patient is having a heart attack. And the patient was brought to our hospital. A brief history was taken, and verbal consent for an angiogram was taken in the patient's best interest because the patient was actively having a heart attack. And one of the things that we do when we are doing an angiogram in the emergency setting in a patient who's having a heart attack is if we find that the artery is blocked, it's often, well, not often, always blocked because of a blood clot, and we can aspirate the blood clot. And just to show you, hopefully not for the faint-hearted, but this is what actually blocks a coronary artery acutely to cause a heart attack. So this is actually blood clot within the artery that has been aspirated, and once that's been sucked out, blood can flow again down the artery and the patient feels better instantly. Of course, that's what we're trying to avoid. So, in summary, hopefully in this last 30 minutes or so, we have understood what coronary heart disease is and the extent of the problem, that we recognise it's the leading cause of death in the world year on year, and that actually 70% of these cases are preventable. And they are preventable if we can understand the major risk factors for coronary artery disease and try to reduce the risk. And hopefully we've gone through some of the ways that you can lead a healthier lifestyle and make some better choices to be able to change those modifiable risk factors that are basically lifestyle driven. So smoking, hypertension or high blood pressure, physical inactivity, high cholesterol, diabetes. And hopefully you've also gained a broad overview of some of the symptoms of heart disease, some of the investigations that we perform either in the clinic or in the hospital setting, and some of the treatments for coronary artery disease. And with that, I will thank you for your attention and for the opportunity to speak to you today, and welcome any questions.
Thank you, Doc. We have the first question, which asks, Doc, I'm assuming shisha would have the same effect as smoking too.
Yeah, so obviously this is a cultural shift. So I lived my entire life in the UK before moving to Dubai about 6 years ago, and other than certain streets in London, you don't see any shisha in the UK really, but here obviously it's a cultural experience and you see it everywhere, and therefore because it's a kind of socially accepted practice, people think it's not very harmful, but honestly it's just as harmful as smoking cigarettes, if not more so. And the reason I say that bit is there's no filter in a shisha. You just simply are having purified tobacco, and you may not inhale, I guess, as deeply into the lungs as you would do with cigarettes, perhaps. But equally, what I say to my patients is my observation of people smoking shisha is that you can sit puffing on a pipe for 1 hour, 2 hours, 3 hours, chatting away. And nobody really ever smokes a cigarette continuously like that. You smoke one cigarette, you go off and do an hour's work, 2 hours work, you come back, you have lunch and maybe have another cigarette. And so really over the course of an hour, and there's no science to this, by the way, but this is just kind of my observation and how I put it to my patients. I would say that smoking shisha for an hour is about the equivalent of smoking 10 cigarettes. And that's how I put it to my patients. And again, there's no precise science to that, but that's just an observation of if you were to puff on a cigarette as frequently as you puff on a shisha, that's probably how many cigarettes you could get through in an hour. And in terms of the harmful effects, it's just the same, you know, smoking tobacco, but actually in a purified way. So yeah, stop smoking shisha as well would be the advice.
No, Doc. Doc, there was a question similar in line. How about vape?
Sorry, I didn't hear that.
How about vape?
Vaping? Yeah, so we touched upon that a little bit earlier in that vaping doesn't have the tar in tobacco. So don't get me wrong, the carcinogenic effects, so the cancer-causing effects of smoker, predominantly are from tar. Okay, so one would expect that vaping has a lower risk of developing cancer than smoking does. However, vaping, you know, it has nicotine, and nicotine is not a benign chemical. So the addiction to smoking is an addiction to nicotine. That's the chemical addiction that you have if you are addicted to smoking. And nicotine itself, as I mentioned in one of the slides, increases your circulating adrenaline levels, and adrenaline is actually, you know, if it's consistently in your system, is actually a harmful substance. It increases your heart rate, increases your blood pressure, and nicotine also causes damage to the lining of your arteries. So nicotine itself is also a risk factor for developing heart disease. So vaping is for sure not benign. We are yet to have the 10-year, 20-year, 30-year data to tell us how harmful vaping is, but for sure it cannot be benign because nicotine is not a benign substance. And then, of course, you know, when it comes to vaping, there's all those other issues about respiratory problems and reactions, you know, lung reactions to certain vapes, which I won't get into now, but there are other harmful effects potentially of vaping. So what I say to my patients is try not to swap one bad habit for a less bad habit, or a less bad habit for a bad habit. And if you are going to vape, use vaping as a means of quitting. So with vaping, you can choose your nicotine concentration, and try to wean off the nicotine, so that eventually, you don't need nicotine, because, as I said, that's the chemical that you're addicted to. So if you are going to stop smoking, switch to vaping, and try to wean off the need for nicotine to quit the habit completely.
Next question is does low BP lead to higher cholesterol?
Sorry, does low BP lead to high cholesterol?
Correct. That's the question.
No. So blood pressure and cholesterol are not linked at all. So having high blood pressure doesn't lead to high cholesterol. Having low blood pressure doesn't lead to cholesterol. Having high cholesterol doesn't affect your blood pressure. So they're mutually exclusive entities. They are both risk factors for heart disease. So if you have both, then they have a synergistic harmful effect, such that the more risk factors you have for cardiovascular disease, the more likely you are, of course, to get cardiovascular disease. But in terms of developing one or the other, they're mutually exclusive.
Doc, is hypertension or cardiac conditions reversible?
Yes. Yeah. So, and this is the point, that's the point of the talk, really, is to say that cardiovascular disease is preventable. Well, okay, so you didn't actually ask preventable, you said reversible. So cardiovascular disease is preventable. So we've talked about the risk factors. We're hoping to never have any of these risk factors, and therefore delay the onset of or progression of atherosclerosis, building up of cholesterol in the arteries. Look, it is part of life. None of us are immortal. We will die of something. We are more likely to die of heart disease, but we're trying to delay when we eventually pass away. And so we can't reverse aging, that is life, but we can slow it down. And so the things that I've talked about today are really about slowing down the progression of heart disease and buildup of cholesterol in our arteries, rather than reversing it. So we can't have that Benjamin Button effect of becoming more youthful as we get older. When it comes to things like blood pressure, what can you do? Well, you can treat blood pressure, obviously, so we give medications and that treats it. But if the question was really, can we do something about it to not have high blood pressure? Yes and no is the answer. So a little bit depends on what are the kind of predisposing factors for blood pressure. The important thing to understand, 95% of people who have high blood pressure do not have an actual cause. So it's not because, for example, their thyroid is overactive or they have kidney disease. Those kind of patients account for only about 5% of the population that has high blood pressure. The rest have it because they have it. Having said that, and I'm doing a little study of my patients here at the moment about this, most of the people I see in my clinic who have high blood pressure are overweight. So for me, again, what I say to my patients is, do your best to have a normal body weight. And until you do, you will never know whether your blood pressure is partly due to your weight or just fate that you were going to have high blood pressure. So keep a normal body weight. Remember the body mass index. It's not a perfect science, I accept. If you're very muscular and have high lean muscle mass, you might have a higher weight, but you are quite fit, and you might be in the overweight category, but that it's all muscle, and that's fine. But for most of us, we're not super muscular, and if we've got a high BMI, it's probably because we've got too much body fat, to be honest. And so use it as a rule of thumb. Yes, it's not a precise science, but try to have a normal BMI. So weight or excess weight is a major cause for high blood pressure. Too much salt in the diet is a major cause of high blood pressure, particularly in this geography where there's high red meat consumption, high consumption of fast foods, restaurant foods, you know, as I said, all those kind of food outlets will have much more salt in the food than you would prepare at home, I would think. So there are, let's say, environmental reasons why people will have higher rates of blood pressure, and why perhaps locally we see higher rates of blood pressure. But the main reasons locally that we see it is physical inactivity, poor diet leading to obesity, leading to high rates of high blood pressure and high rates of diabetes. And for those people, it is reversible. And I've got many patients. I have a book of my biggest weight loss losers, and I set my patients a 10-kilogram weight loss entry criteria to get in the book. And in that book, there are several patients who have been on medications for blood pressure, medications for diabetes, who have lost 10, 20 kilos in weight, and they're no longer diabetic, and they're no longer have high blood pressure. So in that regard, it is reversible, but it depends what your starting point is. You know, if you're 20 kilos overweight, it's reversible potentially. You know, if you're a normal body weight, physically active, have a good diet, but you still have high blood pressure, yeah, unfortunately, then that just might be fate.
Doc, we will just take the last question. What are the alarm signs someone having a heart attack? What are, like, if someone is in an office setting, or you know, what are the alarm signs that possibly it would be a heart attack and the person should be rushed to an emergency?
Yeah. Okay, so really good question, which is why I kind of ended the presentation with a couple of slides on what to do if you have chest pain, what are the investigations, etc. But so a patient having a heart attack typically would be having chest pain. So chest pain, called medically angina, is pain coming from the heart. Typically, it's a pressure, a heavy feeling in the chest, maybe a squeezing sensation. It's usually central, feeling like an elephant or somebody sitting on their chest. It can radiate to the left arm, it can radiate into the neck. Sometimes the patient might just feel it as jaw pain. So it can be different for different people, but typically it's a heaviness, a pressure on the chest that happens at rest if you're having a heart attack, and that's unremitting. It's not, you know, it's not there for a second or two. Any pain that's lasting a second or two is usually nothing serious, but this is unremitting. It's not going away. The patient who's having a heart attack, particularly a serious one, usually is feeling sweaty, maybe nauseated, might even actually vomit, and really feels uncomfortable. Now, I know that sounds like a little bit flippant, but you know, usually somebody having a heart attack knows that this does not feel right, and they are feeling a bit sweaty, a bit sickly. But the main symptom is a pressure feeling in the chest, a heaviness in the chest. And any chest pain that's lasting more than, let's say, 5 minutes, you should be, you know, calling an ambulance or seeking medical attention as soon as you can. Certainly anybody who's had angina and a heart history, those patients should have a GTN spray. So this is the nitrolingual spray, a little red spray, and they should be carrying that with them at all times. And for those patients, if they have chest pain, you should sit down, stop whatever you're doing, take 2 squirts of the spray under the tongue, wait for 5 minutes. If the pain's still not gone away, take another 2 squirts of the spray under the tongue, wait for another 5 minutes. So if you've now had, you know, this kind of central chest pain for 10 minutes or more and it's not going away with the spray, again, you need to call an ambulance and get to hospital, because it is a heart attack until proven otherwise. Okay, so unremitting chest pain, again, textbook definition, lasting 15 or 20 minutes or more, is a heart attack until proven otherwise. And so you need to be in a hospital setting as soon as you can. You should not be driving, which is the other kind of slightly alarming thing that I've seen here a few times, is patients driving themselves to hospital when they think they're having a heart attack. Please do not do that. Not only does it put yourself at risk, but it also puts other road users and at risk as well. So please do not drive. Ideally, you shouldn't get anybody else to drive you either. You should get an ambulance because that's the safest thing to do.
Can you just repeat the spray, the name of the spray which you said, and someone who is at a risk of getting a heart attack, someone has a one or two valve block, can they carry as a preventive thing, the spray?
Yeah, so it's called a nitrolingual spray or nitroglycerine spray. Really, anybody who's had an angiogram and known to have blockages, has had a stent put in, has had a heart attack at some point, whatever, if you've got a heart history like that, you should have a spray. And if you've got a relative who's got that kind of history or a friend, make sure that they have a spray in the house, upon their person. Usually I would give patients 2 or 3, so they've got one they can take to work with them, one that's in their house, maybe one that's in the car or something like that, so that you have that available to you to try and relieve you from your chest pain should you develop it. Yeah, so it's called nitrolingual spray. Sometimes people will give little tablets that you can put under the tongue. It's the same substance, but it's just in a tablet form that you just let dissolve under your tongue. Yeah.
Noted, Doc. Thank you so much, Doc, for your time. It was a real informative session. It is that as important people in the office setting should be aware of. It could be themselves, it could be their colleagues who may be just suffering with, sudden symptoms of heart attack. And it's as important as to how we can prevent these conditions, maintaining
Yeah.
a healthy BMI, like you said.
Yeah, so I think, well, two messages. One very important message: if you have symptoms, you must get checked out. I mean, that goes without saying. So if you have symptoms of anything, you must see a doctor and get it checked out. But when it comes to prevention, if you're over the age of 40, for sure, I would very much advocate on an annual basis to get your blood pressure, cholesterol and sugar checked when it comes to prevention of heart disease, because living in ignorance is not a sensible thing to do. And then, yeah, the lifestyle advice of, quit smoking if you are a smoker, never start if you're not a smoker, regular exercise and being aware of your diet, salt, sugar, cholesterol.